Hello and welcome to the Cases podcast. My name's Emma Park. I'm a GP in Sheffield and clinical lead for Cases. And today we're going to be discussing patients with asymptomatic coronary calcification. And I have here Andy McCoye, who is one of our GPs with a special interest in cardiology and one of our Cases peer reviewers. Andy, is there anything else you want to say about yourself?
No, thank you. It's lovely to be here, and thank you for inviting me to this. So I guess the reason we're here is because recently there's been a bit of a hot topic. Certainly a lot of questions being asked about patients who are asymptomatic being found with calcification in their coronary arteries. And one of the things that's been a reason why it's come to light recently is the lung cancer screening program, which has been going on and finding these recently. So I thought we'd talk about that. There's been lots of questions recently about it. A lot of people ask me when I'm in passing when they realise that I'm doing cardiology. A lot of people text me about this, email me about it. There's a lot of cases, peer review referrals that we've done recently that we've discussed on this topic. So it's definitely something that a lot of GPs are talking about, and not many of them say to me, "Oh, I've got that sorted, I know what I'm doing with it."
Yeah, it's certainly, I mean, the lung screening's moved into our patch and it's certainly caused a lot of discussion in the practice with all these patients coming back. So I think I may have asked you and the other cases peer reviewers about this myself. So yeah, tell me more.
Yeah, so I mean, obviously, first thing to say is it's definitely a good thing, the lung cancer screening. So let's not make any bones about it. It is a brilliant thing to do to find lung cancer early. And apparently, in the lung cancer screening program nationally, since it's been going, they found 5,000 new lung cancers in asymptomatic patients.
I
And they find
hadn't
them early as
realised
well.
that. Yeah, I mean, it's amazing. So it's clearly a good thing.
Like with a lot of cancers, if you find them early and you can treat them, put them on treatment early, then your outcomes are going to be better. And if you find them later, the outcomes are going to be worse. And lung cancer is another one of those insidious cancers sometimes where it can present with non-specific symptoms or be vague symptoms that the patient doesn't present with or are to diagnose as lung cancer. So let's be honest, it is a good thing to have on your patch, and you're going to be finding people with lung cancer that may not have their life saved otherwise. However, of course, what is happening with this is there's mobile scanners around, and they do come to your patch, and they can come any time of the year, and they will do a lot of patients at once. And in areas of socioeconomic deprivation, there might be a lot of people who are on of that age group who have been smokers or ex-smokers, which is the people that they're looking at to try and diagnose lung cancers, who have these scans all in a short period of time. So you might get a lot of these results all at once. So I think we all know what that feels like to have an extra bit of work come in at time. So I think the patients that they have are 55 to 74-year-olds who are either current smokers or ex-smokers, I guess, who are generally haven't got symptoms, signs, or a diagnosis of lung cancer. Otherwise, they would be picked up by other screening modalities. They're people who are asymptomatic as a kind of screening program, but it's not. I guess because of that's such a big group, they can't screen the whole population all at once, and because it needs a CAT scan to do it, it's not like a near patient test like a cervical smear, pap smear, or a Q-fit test, is it? It's got to have some expensive bit of kit that turns up. So they're kind of saying that can happen any time of the year as well. So it might not. You might get the mobile scanner come to your patch even in winter, and there's not a lot we can do about that because they want to get the scanners going all year round. So I think it's one of the things that we're accepting as part of this. But yeah, getting to the bones of this is that when we get the results through, they try and get the results through to tell them whether they got cancer or not. But there are, which is good, but there are incidental findings that happen, and the one that that comes into my space quite a lot is the incidental finding of coronary artery calcification. I suppose
Yeah.
it just be yeah. So there's also other incidental findings, incidental lung findings. So people finding radiographic findings of emphysema that we have to
hmm
kind of deal with. You might find goiters. You might find things in the liver that they can just see. Might be
Yeah.
other breast findings, skin findings, lots of bone findings, of course. So it's not just about coronary calcification, but I think that's what we've been getting most of the work on, because about 60% of these scans in this group show some level of coronary calcification. And calcification, what is it? It's calcium deposits in the coronary arteries, the arteries that supply your heart with blood that carries oxygen to the myocardium, in the heart muscle.
hmm
And if you've got calcium there, it shows up on X-rays and CT scans. But it's
hmm
not very specific. It doesn't say, obviously, if you're looking at an artery that's got no calcium in it, you just won't see it on X-rays without contrast. On a
Yeah.
CT scan, you might see the artery moving around. You might see it still, depending on where in the cardiac cycle it is. So
hmm
I think one thing to say about these CT scans that are spotting incidental coronary artery
hmm
calcification is that they're not the same CT scans that we would use as a CT coronary angiogram. Well, they're not. It's not the
Okay.
same. It's not the same test. I mean, maybe the same scanner, but with a CT coronary angiogram, if you go to cardiology and you're investigating for angina with a CT scan, you would normally have rate limiting medications to keep your heart rate low while they take the scan with contrast so that they can see the coronary arteries. They will see calcification there, but they'll also be able to see soft and hard plaque in the coronary arteries and make an assessment on the coronary arteries of what level of blockage and what degree of
Okay.
blockage there is in the coronary arteries. So it's a different test than you'll have with that the 64 slice CT coronary angiogram that you'll go to if you've been to a cardiology clinic and you've got symptoms of angina is
hmm
different than just having an incidental finding of a CT for another cause. And it's also a little bit different than more similar to the 6 slice CT scan that we were doing about 15 years ago as part of when it was decided that chest pains might be able to be stratified in primary care by doing CT coronary calcium scores. They were 6 slice CT scans just looking
Okay.
for calcification, and then the idea was that we might be able to stratify risk of heart disease and angina based on people who have a good story for angina with that calcification, but that was superseded by more recent chest pain guidelines suggesting it's not the best test for that. But you will still find CT coronary calcium scores done. But I guess with this finding of incidental findings of CT coronary calcifications, you might not just find it on these lungs, the lungs cancer screening program. You might also find it when somebody's been into hospital with and had a CT, like a CT pulmonary angiogram, for instance,
hmm
to rule out a pulmonary embolus, or a CT for other conditions that happens to see the thorax as well. So
Okay.
lots of times when this might happen, often when it's done for a patient who's in hospital under a specialist, they will probably, not always, but it's more likely that specialist will give some guidance about what to do with the next steps.
hmm
But with this, definitely, with the lung
It,
cancer screening, we're definitely getting the results for this and
yeah.
to work out what to do. So
So that's the thing. You get this thing back saying it's got coronary artery calcification, and the patient has never complained of anything. So what should we be doing?
yeah, so you're going to get this as a letter or email or something in your document or your system one inbox, and then what do? Do you act on it straight away? Do you kind of like send a task? Do you phone the patient immediately? Do you wait for the patient to read the result on their NHS app? There's lots of things that go through your mind, and
Yeah.
there's not just one of these. There might be a few that come in at once. So I mean, I think the whatever it shows, we probably don't need to panic. So if it shows lung cancer, then the lung screening program are gonna look into this. They're gonna follow it up. If it shows coronary artery calcification, then up until recently, it was telling us about any coronary artery calcification. I believe from February 2025, they're not telling the patient with the patient's result letter
Oh,
about
okay.
minor coronary artery calcification is now not being mentioned.
Oh,
However, the patient might see it if they read their own results, of course, when they're with the if they've got access to their own reports, or we often tell them about the NHS app to look at the results, then they're going to read it out there and they're going to ask you the question. So that might be a slightly different consultation based on what the patient's seen about their results versus when we're having to contact the patient to discuss something. So we're likely to be dealing with patients who are found to have moderate coronary artery calcification documented on their scans, or severe coronary artery calcifications on the scans. And the question is, how quickly do you act? What do you do? And which of those are important? And who, I guess, needs any intervention, and who needs some medications, and who needs a referral? So, I mean, I could put you on the spot and say, how would you deal with this when this comes in? Do you have a strategy, or would it just be you'd have to do it on the spot and work it out?
To be honest, I read them and then I usually send a task to reception or an ACREX to the patient asking them to book in to discuss it. And then I quickly look up the email that I seem to remember you sent me saying what I'm supposed to be asking the patient.
Yeah. Okay. So, and obviously, not everybody in Sheffield will have had an email from me.
Well,
But
no,
many
not
people.
everybody in
I've probably spoke
Sheffield.
to a
Yes.
lot of people about this. Now, there is an interesting and a really useful correspondence that came out recently from the South Yorkshire screening programme that answers quite a few of these questions, actually, or discusses it, done by Jason Page, who's the lung cancer screening director for the South Yorkshire and Bassetlaw Cancer Alliance. So he's put an FAQ together about the lung cancer screening program and CT. So I would recommend everybody having a look at that. If you've not seen it already, you may have seen, I think it was broadcast in one of the Sheffield round robin emails with updates that came out, but you may have missed it. I've just found it looking at a search engine now by searching for South Yorkshire lung CT GP or FAQ, and it comes up there with some really good questions on that, not just about the coronary artery calcification, but also about emphysema findings on there as well. So
I think that's something we can put in the show notes.
Yeah, that would be that'd be good to do. So hopefully that will be here attached by the time you read this. At this moment in time, there's still and we're recording this in case you're coming back to listen to a recording at some stage. We're recording this in early June 2025. At this moment in time, some of what you do is actually a little bit controversial and hasn't been not controversial, but hard to work out exactly what is the right actions to do. So firstly, contacting the patient is definitely a good idea. If you just leave it, then that's probably not the best idea, because you do need to make sure that the patient with coronary artery calcification isn't symptomatic and hasn't got known angina. If they've got known angina, if they've got symptoms of angina when you speak to them, and they're having chest pain when they're walking uphill, breathlessness that's predictable when they're walking uphill in the centre of the chest, like an ache that when they stop it goes away, or if they borrow somebody's GTN and it goes away, then that sounds like angina. They should be treated in the usual way.
Okay.
According to the NICE guidelines, the CG 126 angina guideline, you would refer them. You'd start them on aspirin, statin, and possibly a beta blocker. Though remembering that we're dealing potentially with people who've got respiratory disease here, so just be careful about anybody who might have bronchospasm if you're starting a beta blocker, or possibly nitrates, GCN spray, checking for reversible causes blood test with ruling out anemia and thyroid problems, and doing an ECG to check for any obvious myocardial damage, and then doing the blood pressure, discussing secondary prevention in those cases. So a lot to do with those in a 10-minute consultation. If you find somebody who's got new angina, I've skirted over that very quickly. So those patients, I think we can probably know how to deal with, but probably out of the remit of this, because we're talking mostly about people who are not going to have any symptoms. The issue, of course, is they might have symptoms that aren't classical angina, but might be slightly vague and could be angina. So if they're a smoker in their 50s, then, or an ex-smoker, they might be a bit out of breath when they exerting themselves, or they might get a bit of discomfort sometimes. So I think if they've got coronary artery calcification and they've got some possible symptoms like that, and if they were a 20-year-old non-smoker, and the same story came out, you might have a pre-test probability being quite low. The idea with this is that the idea with assessing people with chest pain is that sometimes you may have people who are quite high risk just from their risk factors, who has a slightly more vague presentation that still has quite severe coronary artery disease. So if they in this population, if they're breathless and they've got some discomfort, you might still want to refer them, to be honest, if they've got moderate or severe coronary artery calcification. Obviously, like I say, if they've got definite story of angina, then you would be referring them and treating them on you. But if it's slightly uncertain and you might refer them, this might just tip you over the edge to refer them. So just bearing in mind when you send them the Accurix message, or when you get reception to invite them in, I'm just thinking of one of my close relatives who's in this age group, who's just had an invite from her GP a few weeks ago. Was petrified by this, like being told that she had a lung scan and she had a problem with her heart. She needed to speak to her GP, but in a few weeks when they were going to give her a telephone appointment. So it is a bit. There's nothing you can do about that, but it is a little bit. Put yourself in the patient position. Sometimes it can be quite scary whenever you're talking about heart. And, my relative was kind of like then starting to think about wills, and that it was an inheritance, and that was it. That was the end of it, because they had moderate coronary artery calcification, and so you have to put yourself in the patient's situation sometimes to realize that this might create some worry. So sometimes when she went to see the GP, they did a really good job, I have to say, explaining it to her very well. And that's what we kind of want to do. It's another consultation that's going to be difficult in the usual 15 minutes, of course. You're going to be bringing them in, having this discussion, explaining what coronary arteries are, explaining what calcification is and why they found this when they're looking for lung things, explaining that it's nothing to do with the lungs, and then also having to take a bit of a history as well to work out whether they've got any heart symptoms. If they haven't got symptoms, then making some establishment of the risk. So the question you're probably going to ask me is, if you've got some moderate or severe coronary artery calcification, is that primary prevention or is it secondary prevention?
Well, yes. This is so what would you say?
It's controversial, to be honest. It is so I would say if you incidentally find the minor coronary artery calcification in an asymptomatic patient in this group, the minor is kind of expected. It's one of those things, you're getting older, you smoked. there is some calcium around, you don't really need to do anything about it, I wouldn't have thought. I mean, obviously,
Okay.
everybody could have lifestyle intervention at the next opportunity and be warned about the risks of smoking and
Hmm.
have their primary prevention risk evaluated, of course, but I wouldn't make a specific, if I saw this in a report, I wouldn't necessarily contact the patient about the minor finding, and I probably wouldn't
Okay.
mention it if it was incidentally found it on a scan for something else. The moderate ones, I would invite them in, and again, not urgently
Hmm.
with this. We're looking at quite a high risk primary prevention group here, and I would call the mild and the moderate prime prevention, even though there's something happening in the coronary
Yeah.
arteries with the calcification. It's not until they're symptomatic or they're
Yeah.
proven otherwise. It's not ischemic heart disease. It's not causing ischemia there. So, in my opinion, and many people's opinion, we're probably still treating this, evaluating
Yeah.
this as primary prevention, looking at the Q risk 2 or 3 or other risk factor scores to work
Hmm.
out whether they require intervention with their blood pressure, with their
Hmm.
lifestyle, with lipid modification. So probably either some blood tests might end up there, checking blood pressure might end up there, asking them
Okay.
about symptoms. If they're asymptomatic, that's fine. Then you can work on the Q risk. But most of the patients in this cohort, so over
Hmm.
55 smokers or ex-smokers, significant smoking history, the men are almost all going to have a Q risk of over 10%. So all
Yeah.
probably going to need statins. Apparently, the women, females, because slightly lower risk, that some of the people under 60 might still be just below that
Yeah.
10% level. So
Because wasn't,
I would work out the Q risk on with
yeah,
these people.
I was going to say, because wasn't there a suggestion a number of years ago that we should just have all men over 50 on like a poly pill, a statin, something for their blood pressure, and an antiplatelet?
Yeah, I suppose as soon as you leave school, you started on blood pressure medications, aspirin, statin, etc. When would you? Obviously, every intervention that we do, whether it's a
Yeah.
surgical or a medical intervention, has potential risks, and of course, the dogma is first do no harm. So,
Hmm.
although a statin is going to definitely have some prevention
Yeah.
on your coronary arteries and reducing your cholesterol, which also reduces the chance of having cardiovascular events in the future.
Yeah.
There's no doubt about that. There are also some morbidities related to lipid modification, both in the quality of life and the side effects of statins. So, as you know,
Hmm.
we get people who have problems with muscle aches and pains, liver problems, and
Yeah.
sleep problems, among other things, many things, and the gastrointestinal effects with them. So some more than others.
Hmm.
That's why um, one of the reasons why we don't put everybody on a statin over a particular
Yeah.
age, because some people are still quite low risk, even though their biological age is, is getting on a bit. Some people, I'd rather give the 49-year-old diabetic hypertensive angina patient
Yeah.
the statin than the 70-year-old lady who's very healthy and vegetarian and BMI of 20
Yeah.
and does lots of exercise and has no family history, no normal blood pressure, normal cholesterol, etc. So I wouldn't just go off one of those factors.
Okay.
Although apart from possibly type 2 diabetes, which is obviously is a particular high risk and has
Hmm.
its own uh, way with it as well. So I would evaluate those the cardiovascular risk for those patients and
Hmm.
give them a statin if the secure risk is above 10%. Would I give them
Hmm.
an aspirin? Would you give them an aspirin, Emma?
Oh, I think that would depend on their Q risk, wouldn't it? Because I'd sort of be a bit worried about bleeds and
Again, yeah. So we've got to think about
yeah,
not doing no harm first. So,
yeah.
but you and I probably are old enough to remember that before about 2007, I think we used to give anybody who had
Yeah.
a Q risk or the Sheffield tables
Well, I
risk
was about to
above
say
10%.
Sheffield tables, yeah, which
Yeah,
is
so
very old school.
we're
Yeah,
really kind of like remembering well here, aren't we? So
yeah.
those people, we used to give aspirin all the time for primary prevention
Hmm.
above a particular risk, knowing that so aspirin does do
Hmm.
some benefits for primary prevention. It reduces your risk of cardiovascular events if you're at risk, of course, but it's we changed our practice
Hmm.
15, 20 years ago to not give aspirin in primary prevention because generally the risks of bleeding, side effects with
Hmm.
aspirin weighs that risk. But then we're now in another category of patients who not only have the risk of smoking and age,
Hmm.
and possibly other things, they've also got this coronary artery calcification that's there. So that
Yeah.
will definitely put them up to a higher risk. So we're not just we're not just comparing those with the average population. We're comparing those with other people who've got coronary artery calcification. So they're going to be
Hmm.
at slightly higher risk than somebody who doesn't have that coronary artery calcification found on a CT scan. Coronary artery
Yeah.
calcification is an independent risk factor for cardiovascular events when we find it. So, but does that mean you do anything about it? Do you do the making them worse, risk making them worse to on the gamble that you're going to make them better? That's the
Yeah.
kind of um, that's the dilemma you've got with these things. And to be honest, this is still undecided nationally and internationally about what you do in these situations. So
Hmm.
the severe coronary artery calcification, if it says that on the report, then I suspect
Hmm.
most of the people seen a lot of those people referred now to cardiologists, whether they've got symptoms or not. So I think most people probably are referring those, but I
Okay.
don't necessarily think it's essential to do so. I'm also seeing most people get aspirin in that situation.
Hmm.
And if it says severe, then perhaps yeah, I think you could be right with that. But you could also be okay to not give aspirin if they've
Hmm.
got no symptoms. It possibly still is primary prevention. It possibly, if it's severe, is secondary prevention. I would say, this is my opinion at this moment
Yeah.
in the middle of 2025, I would say this is primary prevention when it's mild and moderate, and then
Okay.
probably more likely to be secondary prevention when it says severe coronary artery
Hmm.
calcification there. But if I'm honest, I'm not 100% sure. And if I'm honest, speak to my cardiology colleagues, I don't think there's a consensus there as well. They're
Hmm.
in Sheffield, they're discussing it around about now and trying to guide us on when to start aspirin and when to start statins. I think the statins are
Okay.
a little bit, from what I've said, they're a little bit easier.
Hmm.
You could start statins on anybody based on whether it's primary or secondary prevention.
Hmm.
Would you start beta blockers, angina treatments if there's no symptoms? I would say no. Would you give them a GTN spray? No. Would you
No.
refer them? Probably you wouldn't if they are asymptomatic, but I would have that discussion
Okay.
about what if they were going to, if they start developing chest pain,
Hmm.
exertional breathlessness, dizziness, those sorts of things, and
Yeah.
modify their risk factors if they're so the secondary prevention things. Would I start aspirin? Sorry, the severe coronary artery calcification were they're more likely to be secondary prevention. Would I start aspirin with those? Possibly, yes.
Okay.
And would I refer them? I probably wouldn't if they weren't symptomatic this moment in time, though I expect
Yeah.
guidance will probably come out to help us on this in the coming years, I hope, with this. So if they were already on aspirin
Hmm.
and they have mild or moderate coronary artery calcification, would I then stop the aspirin at this stage? No, I probably wouldn't. I'd probably let them carry on with that, but it's a patient-centered approach really. So I would want to speak to the patient about those things. As I say, if it's mild, then I may not be seeing them anyway. If it's moderate, the coronary artery calcification, I think like yourself, I'd have been asking them to come in to have a discussion or even a phone discussion on this, but phone's a bit difficult because you can't check the blood pressure and get a good feel for exactly what their situation is at that time. And they probably more likely, that might be controversial to say. Is it controversial to say they might be more give you more of correct information in person than on the phone? I don't know. I sense that they might do.
Sometimes I find it's easier to have the conversation when you're face to face rather than on the phone. So I probably say it's not that they give you more accurate information necessarily. It's just easier by the time you've gauged the non-verbals and things like that.
Yeah. I think so too. So as I say, there's a bit of it's not a guideline or a guidance that's been given on this information document that's been given by Jason Page and the Lung Cancer Screening Alliance there, but it does give quite a good flow chart for what to think about with CAC, with the coronary artery calcification. Some of quite a few of these things that we're discussing are on here as well, and about the benefits of the lung cancer screening program. So I think check that out if you refer to cases. So if GPs kind of like see these results and then have the discussion and they're not sure and they refer to cases or cardiology, then we often link some of we often say there's no consensus on this, but we often link some of the guidance from the Royal College of Radiologists or some of the cardiology guidance to do with the specific age and types of patients. So sometimes we're a little bit more specific with our advice on this, I think. And sometimes we won't have enough information as peer reviewing GPs to kind of say definitely don't refer them. We'll let it go through to the cardiology specialist for some advice and guidance, because as we know, we've been talking about patients who only have one condition here, haven't we? But real life patients are much more complicated than this often, and much more baggage and comorbidities to think about.
Okay, yeah. Oh, that's really helpful. Thank you. Was there anything else that you'd wanted to cover? Because I think you've covered most of my questions at any rate.
Obviously, a whole new subject, whether we discuss symptomatic chest pain and angina and coronary artery disease, that would take a much longer
well maybe we can do another part two. Yes. Yeah, it might be useful.
Yeah. And I guess these things will be updated at some stage. We'll have more idea about what's going on, and we'll have some updates about what we should be doing with this incidental finding. But I hope it's helpful to discuss this, because I think a lot of GPs are having a lot of time to think, having a lot of the time taken up thinking about this, having these discussions with patients.
Well, I think it's
a common question asked at the moment.
It's something new that we've just happens, and it's not something we've thought about. And I suspect that once we've listened to the podcast, looked at the document you mentioned, it will become easier and clearer to know what we're doing with it. It's that kind of, oh my word, I've never seen one of these before. What do I do? That I think throws you. And once you've got your head round, oh right, well, this is how I do it, this is how I think about it, then it becomes more straightforward.
Yeah, and so I don't think you can just file them and leave it to somebody else. Then that nobody else is going to look at these. I don't think the Screen Alliance aren't going to do it. No. So I think even though it's one of those things where it's slightly at odds with our usual GP mantra, or doctor mantra, clinician mantra, that if you do a test, you follow up the results.
Absolutely.
With this, it's a little bit more complex than that, I think. But let's remember the taking a good history if we can, and let's remember smoking cessation, really important, of course. So if they are still smoking for many reasons, let's try and get them onto smoking cessation therapies, treatments, and advice, and keep badgering them to do that for them, their family, and their descendants. I think the smoking cessation is super important with these and other patients.
Yeah. Oh, that's great. Thank you so much, Andy. That's really helpful.